Hi everyone, my name is Sheena Lawrence. I manage the New South Wales Cancer Registry at the Cancer Institute, and I'd like to assure the last two speakers we're working very hard on updated data, so you'll have that soon. Our registry collects data for national reporting and also use in population-based research, as we've already seen today. Last year we completed a project with Cancer Australia to collect stage data. In this presentation, I'm just going to give a summary of a study we've done this year where we've analysed the staging information held within the registry. So, I'm assuming that most people in the room know what cancer staging is, but to confirm my assumption by backing it up with actual data, can you put your hand up if you know what staging data is? Fantastic. So that's an example of lung cancer staging. And these are some examples of how staging data from the registry has been used for population-based research. There's lots of different ways you can stage a cancer. In the registry, we've collected summary stage, which we call degree of spread, or might sometimes be known as extent of disease, and we've been collecting that since the beginning of the registry in 1972. In this system, tumours are categorised into 4 groups, which you can see up there, and it's defined by the International Agency for Research on Cancer. The T&M staging system, or tumour node metastasis stage classification, is developed by the American Joint Committee on Cancer, AJCC, and is widely considered the gold standard staging system. You can see here in the example for lung cancer, it's really comprehensive. There's lots of sub-staging and lots of rules that go along with how to stage a cancer. T&M is collected in the New South Wales Cancer Registry, but it's not at a population level, and it's not for all LHDs or all tumour groups. When we spoke to other population-based registries in Australia, we know that it's underreported or it's not reported at all. So in an initiative to improve national stage, Cancer Australia developed and funded a project which put together a methodology to derive the best estimate of T&M staging. Referred to as registry-derived stage, or RD stage, it reflects T, N and M values obtained from notification sources within the registry. So what we've got to hand, what we routinely have available. Some business rules were developed based on the AJCC rules, and they were developed by the Victorian Cancer Registry and ratified by the Australasian Association of Cancer Registries. Lots of acronyms there for you. In the project, we looked at 5 cancers diagnosed in 2011. We looked at prostate, colorectal, breast, lung and melanoma. In our registry, some of those cases were already staged. So you can see we have some that have T&M staging, but then a whole lot didn't have T&M staging. So it's those ones that the coders within our registry pulled out and coded manually. The registry system also underwent some development. We developed automated business rules that would then derive this RD stage for all of those cancers, both the ones that were already T&M staged and the manual ones. So we ended up with 26,000 cases that now have 3 different staging systems data. So we've got the registry-derived stage, which was put together by the business rules. We already have business rules that derive the more specific stage group using AJCC T&M, and we have degree of spread, which we've been collecting for many, many years. The project was really great, and it provided for the first time national stage at diagnosis. The data was publicly released earlier this year by Cancer Australia. You can see it up there on their website. And it was a significant project, but in New South Wales, it required a whole lot of resources, from application development, testing, quality assurance, as well as substantial manual effort in collecting those staging from notification sources. Degree of spread is assigned by all coders as a routine part of their job. So it's been collected for a long period of time, there's a lot of rigour around it, and it's provided staging information for a whole lot of population studies. So this year we did an evaluation, because what we wanted to know was is there a point in continuing to collect registry-derived stage? We wanted to use all of that data that we'd collected, 3 different staging systems for all 26,000 cases, and find out whether registry-derived stage can provide something that degree of spread can't. Specifically, for the 5 cancers, does registry-derived stage provide more complete staging, because that would be an advantage, or does it provide more accurate staging, because obviously that would also be an advantage. How did we evaluate it? So we put together some expected mappings. We looked at both registry-derived stage and degree of spread and how well they agreed with the gold standard T&M staging. You can see here that for colorectal, for example, we found that all 3 staging systems have a near linear alignment. They're almost exactly the same. Whereas compared to degree of spread, registry-derived staging provides a better alignment to T&M, especially for prostate and breast cancers, where degree of spread can be mapped to multiple T&M stages. We also looked at completeness. So on this chart here, the light colour is where T&M pre-project. So that's the T&M staging that we already had in the registry. And you can see that it's variably collected depending on the tumour group. And then post-project, or degree of spread, is also looked at pre-project. So degree of spread had a much higher completeness. But then post-project, once the coders had staged those 26,000 cases, the registry-derived stage shows a much higher completeness across all tumour groups. The other thing we looked at in our evaluation is survival analysis. So in epidemiological analyses, stage data is most commonly used to evaluate outcomes like survival. We compared survival models across all 3 of the stage systems. This has also been done in other studies across internationally, in Canada and in the UK. And when we looked at the survival models, they were pretty similar across all 3 of the staging systems. We've got the results for lung cancer, stage 4 lung cancer there. You can see that the numbers are quite similar. For the odds ratios and hazard ratios, we get good agreement. T&M being the gold standard obviously turns out as the best, but it's good to see that all 3 are really similar. So what did we find? The conclusions were that registry-derived staging definitely improved the completeness and also the accuracy for prostate cancer. Degree of spread aligned almost exactly to registry-derived stage for colorectal cancer, and so for the amount of effort in collecting registry-derived stage, there wasn't a huge advantage over degree of spread. For the other tumour groups, the value is less well defined. I think we'd need to have a really good, robust discussion with all of the national registries to talk about the way forward and how we collect in a standardised way for national reporting, where we're going to get the most value there, where it goes on a national stage. This is a picture of some of the wonderful people who participated in the project last year. Some of them are here in the audience, you can have a chat to them. And I just wanted to say that when we looked at continuing collection of stage at a population level, there are things that impact that, there are dependencies. And some of those I've got up here. Obviously, we have other clinical registries that are collecting a whole lot of data, and so we have to look at how we align or link to those, and maybe that provides a better outcome for us. We're also looking at automated data collection from electronic pathology reports. We're using some really exciting artificial intelligence algorithms. We've got a poster outside, go and have a look, have a chat to the team. And we might be able to extract data in an automated way, and that'll improve the resourcing load in order to collect data, stage data at a population level. And then obviously, as we absorb more treatment data into the registry, both chemo and radiotherapy data, that's going to have an effect on the way we even look and record stage data, whether we do it at diagnosis, across multiple episodes, and how that interacts with neoadjuvant therapy. The registry-derived staging data is available for use, so go to the website, the Cancer Institute website, and get that registry-derived staging data and do your own analyses and feed back to us and let us know what you think. Thanks.
Thanks, Gina. Obviously, stage is the most prognostic and important variable to any analyst. So any change in how it's collected and the quality has big implications further down in the analytics space. So can I throw it open to any questions, please? Yes, one from you.
This is very good, but did you check, for example, your staging, registry-derived staging, with the staging from radiotherapy data set or from the admitted patient data set? Or just you got it?
Just within the registry.
From the registry.
Yes.
And how did you do with the unknown and the degree of spread area? Because we have a category is as unknown, I mean. How did you do? Yeah.
So in the analysis, unknowns were excluded.
Okay.
Is that right? Yes.
Okay. Thank you.
Thanks.